we know that still the definition of glaucoma is not that clear. Lot of investigations are done to add to the diagnosis to understand the mechanism and so many things. So several limitations has been encountered with the reference standards of the gonioscopy, which is the most important part of the examination of the glaucoma. So intersegment imaging provides non-invasive, quantitative as well as qualitative evaluation of anterior chamber angle, as well as the pathology related to the sulcus and the ciliary body. AS imaging has been shown to have performance in the angle closure detection compared to the gonioscopy. Imaging has a greater reproducibility and very small learning curve with a better documentation. So in the next 1 hour, we will have various presentation. We will teach you how to identify various structures while doing the performance. Nobody can replace the gonioscopy. So the first part of the presentation will be on the how to identify the angles using gonioscopy and what could be the limitation in the. So Dr. Shweta, please continue. We will take questions at the end of all the lectures.
A very good afternoon to all. At the outset, I would like to thank the Scientific Organizing Committee and especially Dr. Mayuri Khamar ma'am for giving me this opportunity and making me a part of this IC. So today we are going to deal and talk about that how do we evaluate the angle with gonioscopy. The angle structures, the landmarks is commonly well known, but actually this gonioscopy, which is known to be a reference gold standard for angle evaluation, does it has any limitations? Let's see that actually what is the situation. So glaucoma, commonly known as the silent thief of sight, which is the most common cause of preventable blindness, but that's an irreversible blindness, has got the concept and definitions and classifications changing and evolving over a period of time. So only if we timely know that where we are standing with our patient, definitely a timely intervention can help us to prevent this permanent blinding condition. Looking at the projected global prevalence of glaucoma burden through 2040 by this meta-analysis done by Cheng et al., which said that it's a huge increase, especially when we talk about the Asian countries where we reside. There's a huge increase from 46.24 to 66.83 million people going to suffer as an estimate burden of glaucoma. So again, talking about the Indian scenario, as we all know, that angle closure is a more blinding condition and it has got, I can say, a faster progression as compared to the open angle glaucoma when it is uncontrolled. So by these several studies done in our own country, we can see that the blindness is caused by more of the angle closure state. And the minute we talk about angle closure state, it comes something about the angle closure. So before we proceed, let's see that actually what is angle closure. Basically, it is a disease of overlap. Maybe overlap at the level of pupillary block, could be a plateau iris, could be the position of the lens, or could be a thick iris or a hump. So to simplify this, we can understand simply that the block could be at the level of iris or the pupil, could be at the level of ciliary body, or could be at the level of lens, that is lens-induced glaucoma. Retrolenticular portion could be causing malignant glaucoma. So these all are the portions where the angle closure can take place. Only if we are able to define each and everything, each and every structure is, we are able to identify basically the pathophysiology. That because in glaucoma only one funda works, that you know the pathology, you treat the disease. Only controlling the pressure is not going to help us. So we need to be very clear and precise about the diagnosis. Because as we know that the, even with this study done by Thomas et al., that even if we have done the PIs in the cases of primary angle closure, they tend to progress to PACG also. So that means a timely intervention and evaluation, even after you have done and performed a PI for your case, is really required. So the role of the gonioscopy is basically the correct and precise diagnosis of the disease, along with the dynamic indentation gonioscopy, which is referred to the current reference standard for assessing the angle structures and their configuration. I'm not going to go in the details of the angle structures because we all know that. Let's see some common case scenarios where gonioscopy can help us, and where the newer modalities which are coming into picture gradually, how they are going to help us and aid to the further diagnosis of our patients. Let's talk about this particular case where the patient presented to us with a closed angle, and on performing a PI, the angles were opening with difficulty on compression, or they were not opening at all. So actually the story started here. Though this picture is not the corresponding picture of the previous gonioscopy, the same patient, but yes, this was the clinical scenario, which is little difficult for a beginner to identify, because this is the structure where a person should be highlighting while doing a gonioscopy. But that's very easy to just overlook that particular changes, because this is the double hump pattern. Your scenario is going to be a patent PI, IOPs is still on the higher side, or angles are not opening. So that means, that's why it's always said that after performing a peripheral iridotomy for your cases, please go ahead and do a repeat gonioscopy. And then you see, and when suppose you have missed this diagnosis, so this can be further confirmed by this particular modality, that's UBM, which shows you the anteriorly placed ciliary body with obliterated ciliary sulcus. So in case, if you miss it via gonioscopy, that's a reference gold standard. That too, we are talking about the beginners, the first year residents, then probably you can just take a help of this added advantage of this particular diagnostic modality. And the minute you label anybody as having a Plateau Iris configuration, try to differentiate it with the pseudo Plateau Iris. That's something behind the iris or the ciliary body. And here is the, I should say that there is emphasis is needed, because the management strategy changes for both the conditions. Why I am talking so much about Plateau Iris? We all know that angle closure, most common cause of blindness. Angle closure, progression at a faster rate if the disease is not getting controlled. But what is this Plateau Iris? Because we know that angle closure is a disease of a growing age. And if you see a young individual with angle closure, that should raise your doubt or suspicion that the individual is going to have a Plateau Iris. Let's see through several studies done in our country, that is a first study done by GC et al., who said that the anteriorly directed ciliary process were seen both in eyes with Plateau Iris and as well as the eyes in PACG, despite the fact that they were having a deep anterior chamber, even after anterior, iridotomy. So it's not that anterior chamber is shallow, or the anterior chamber has deepened after performing iridotomy and the job gets over. No, actually the job starts, it initiates from there only. Now this is a Plateau Iris. Again, I'm talking about the neurodiagnostic tool because I have been assigned to talk about the limitations of gonioscopy. So when we know that all of us must have come across a child or a kid performing a gonioscopy, and we know that it's a Herculean task. So again, this neurodiagnostic modality, that's UBM, help us to diagnose Plateau Iris in children also. So we can say in all, with the help of this particular study, that approximately 30% of the eyes with PACG have Plateau Iris. The component of Plateau Iris is always there. Now, again proceeding further, we have been talking about Plateau Iris, we have been talking about the PI. So the procedure is, we do the PI, we evaluate the patient on a slit limb examination, and we say, okay, the PI is open. But what if your pressures are still hiking, and your pressures are hiking, and still you think that your PI is patent? But actually the PI have got a residual membrane, as seen in this image, which is seen by an anterior segment OCT also. So again, gradually you can see that how the ASOCT and UBM is coming and sweeping his role in the diagnostic armamentarium of glaucoma. So let's see that angle closures, what do they have more to say? as seen by this study done by that's a ZAP trial, which says that the angle width, which is a very important determinant of the angle closure, especially the patients who are having, they are prone for angle closure. They see that after laser PI, the common thinking is, okay, the ankle is open, we have seen the disc, nothing is going to happen. But no, actually, you have to just see on that patient and monitor that patient throughout his lifetime, because this ZAP trial says that the angle width remained stable for 6 months, but then decreased significantly by 18 months after LPI. That means it is not only a question of 18 months, it's a lifelong tenure that you have to continue monitoring your patients, along with gonioscopy and many other things which we have to talk about. That's the thing comes here, the role of the quantitative measurement of the angle. With the help of what? Obviously, it's not going to be gonioscopy. It's going to be certain other modalities like anterior segment OCT or UBM. Because whenever we talk about the angle width or an angle closure or an eye which is more prone for an angle closure attack, a larger iris volume, smaller anterior chamber volume, or a greater pupillary diameter, everything it comes down to the same thing, reducing the angle width, thus making your patient more prone towards the angle closure attack. So only if you know that your patient is having these many risk factors besides having an occludable angle or a suspected angle, then only you can prevent your patient from further future attacks. Now, whenever we are talking about any new modality, we have to standardize it, titrate it with the already occurring diagnostic modality. That is, we can say that is a sort of agreement. So this agreement was done by Bhaskaran et al. Through one of the studies, which said that there was a moderate agreement between the SSOCT and this gonioscopy. Now, these are the several quantitative measurements which anterior segment OCT or anything can give us. And here the study done by Cheng et al., they even identified that the iris bowing that we think as a beginner, that might be a very small thing. The question comes, iris bowing hai, kuch nahi karna hai, but it's not like that. Even a parameter like iris bowing has a significant role to play when it comes to the angle width independent of the anterior chamber depth. So always we have to look for the additional risk factors in the form of iris curvature, volume, and area. So again, coming back to some of the clinical scenarios, you see a case in your clinic which is having a history of trauma and a persistently low IOP. So what do you think? That it could be a CD cleft. Again seen by a UBM. This is a case where would you like to see pupillary block along with posterior synechiae. You want to see that what is happening to the iris lens diaphragm. UBM comes to your rescue. This is a case where gonioscopy shows a pupillary, there's an angle closure, but actually it's not a pupillary block, it's an angle closure with the pseudo-choroidal effusion, which is the management is going to be held by only steroids usage. Assessing the bleb function, then the limitations actually of gonioscopy is going to be pure documentation, learning curve, no measurements. And when the study was done, there was perception that there is upgradation of gonioscopy which is required. Even the residents, they gave the feedback. Community-based study says that there is a gradually phasing off of the use of the gonioscopy. So I would like to conclude my talk by leaving a pointer here that, okay, we are okay with the newer modalities which are coming into picture, but yes, we need to redefine and reconsider the current definitions and methods used to diagnose and manage the primary angle closure disease. So all these newer modalities can be used as an adjunctive tool. Thank you very much.
Thank you, Shweta, for such a nice talk. The question we will take in the end, take home the message that I would like to pass here is, though she has elaborated a lot on the Plateau Iris, how the imaging plays in the role, but the gonioscopy is a gold standard. All the patients should have a dynamic gonioscopy also. That cannot be done with anterior segment imaging. You can see the pigments, blood vessels pass using the gonioscopy. And it should be repeated if the patient has undergone any procedure, or maybe yearly. It should be the occludable angle can be occluded after 1 year, 2 years. So yearly repetition of the gonioscopy. Anything you would like to add, Chandrima?
Yeah, absolutely. I would go with Dr. Mayuri that gonioscopy remains the gold standard, and it's gonioscopy, gonioscopy, and gonioscopy. And as Shweta said, that that's only an adjunctive tool if you're using the anterior segment OCT or the UBM for that matter. But please don't forget to do a gonioscopy before you diagnose a glaucoma or before you write an anti-glaucoma drug. Please remember to do gonioscopy.
Okay, thank you. Now, Dr. Medha is busy with her talk somewhere else, so she will talk in the later half. We have Dr. Purvi. She will be talking on role of UBM in primary angle closure glaucoma. Any questions in between till she is ready? Okay.
Yeah, so good afternoon all, and again thanks to the AIOC Scientific Committee and Dr. Mayuri Madam for this IC. I'll be talking on ultra biomicroscopy in primary angle closure glaucoma, and some of the content has already been shared, but I'd like to elaborate more on that. Primary angle closure disease, if we say, it is emerging as a leading cause of blindness worldwide, and it is visually more destructive and more blinding than primary open angle glaucoma. And it is responsible for most of the glaucoma blindness that we see in our continent. So it is very, very important to diagnose this condition and to diagnose it accurately and as early as possible. Of course, gonioscopy, it goes without saying, it is a mandatory tool whenever you talk of glaucoma itself, whether it's a suspect or it's an established case, it's a follow-up case. Gonioscopy is absolutely mandatory. It gives you a lot of information, especially when we are talking of primary angle closure glaucoma conditions. But sometimes you want more information, either quantification of whatever you have already seen on gonioscopy, or sometimes when gonioscopy does not give you the information, it is not possible, and then you want some new information. And that is where UBM comes into picture. It gives you true cross-sections of the angle. It has a significant amount of objectivity and therefore reproducibility. It allows quantitative measurements and has a significant amount of measurement precision. So let us see the conditions where UBM is very, very helpful, especially talking of primary angle closure disease spectrum. So the first confusion is whenever you see pigmentation in the angles and you are confused whether this pigmentation that you see is in an open angle or it is a closed angle, and whether it is abnormal pigmentation or it is the trabecular meshwork. So the first confusion is this angle, what you are seeing, is it open or closed? So UBM here helps you to show the relationship between peripheral iris and trabecular meshwork, assess the configuration of the iris, the site of iris insertion in relation to the trabecular meshwork and scleral spur, and finally it helps you to determine the occludability of the angle. So these are conditions where UBM plays a definite role to see between open and closed angles. So here you can see the configuration of the angle. And you can see the angle recess is reasonably open, and here you can see it's an entirely narrow and almost a slit-like angle recess practically closed. So that will help you to determine whether a YAG PI would be helpful in this case or not. Also for the iris insertion, both of them are actually angulated iris, but here you can see it's a posterior insertion and the recess is there, but here you can see it's an anterior angulation, again closing the angle totally. So again you can easily confirm between an open and closed angle. Then the insertion of the iris in relation to the trabecular meshwork and in relation to the scleral spur. So here you can see the thickness of the iris is the same, but this is an anterior insertion closing the angle, whereas here you can see it is angulating posteriorly and it's inserting posteriorly. So again you can see the difference of the angle recess in both the conditions. It also helps you to do the darkroom provocative test. You can do a UBM pre-exposure to darkness and then post, and again you can see whether the angles are opening. So this is on normal illuminated conditions, and this is after exposure to darkness for about 20 to 25 minutes, and you can see how the angles are closing. So again, these are angles which are easily occludable, and you might want to do a YAG PI in these cases. Again, certain conditions where gonioscopy is not going to give you any information, example in corneal edema, post-intraocular pressure rise in acute angle closure glaucoma cases. So here again, doing a UBM would yield important information. You can see the typical iris Bombay configuration, and here you can see the angle is totally closed with synechia. Then you have done a YAG PI, but you are not sure whether it is patent or not because of a dense arca senilis. So again here, a UBM will tell you about the patency of the PI as well as you can measure the size of the PI. So anything less than 200 microns, you might want to enlarge the PI. Again, you have done an intervention in an angle closure, but you are not sure how much actual quantification of angle opening has happened. So there again, UBM will help you in the quantification. This you can see on retroillumination, a very large and decent PI. It's obviously patent, but when you do the gonioscopy, you can see the angles have not reasonably opened up. So what is the cause of non-opening of the angles, and you're not sure what is happening behind the iris and in the angles. So here again, UBM will be helpful. This we have already seen, Plateau Iris, which causes about 20% of the angle closure glaucomas. And here this is one condition where nothing but the UBM will help you. Because even the anterior segment OCT, we know it does not reveal information about the structures which are posterior to the posterior pigment epithelium. And therefore, you will only need the UBM to diagnose this condition. And you can see the anterior rotation of the ciliary body totally anteriorly rotated, and it is pushing that peripheral iris. You can see here, and the anterior iris insertion and the ciliary sulcus, it is totally absent. So this is a confirmatory sign of Plateau Iris, which can be confirmed only on a UBM. Another condition, though this falls under the category of secondary glaucomas, but it needs to be kept in mind, is the pseudo Plateau iris, where iris cysts being the second commonest cause of angle closure in the young patients. So you do a UBM, and you can see either those posterior surface iris cysts or ciliary body cysts or masses. And on gonioscopy, they will be just seen as small humps or bumps in the iris and localized elevations. Again, this is something which we see on gonioscopy, a typical volcano sign, what we call, or a Mount Fuji sign. And here doing a UBM will actually tell you what is the lens volt and the lens thickness. So you can measure the lens thickness, and this is the lens volt. That is the distance between the anterior pole of the lens from a horizontal line joining the two scleral spurs. So that will tell you whether lens extraction will be helpful in these cases or not. So these cases, you can see, obviously both of them were high, and we did a lens extraction, an early lens extraction in that case, and you can see a pseudophakic eye and significant change in the curvature of the iris, as well as significant deepening of the angles as well as the anterior chamber. UBM also helps in the biometry of the anterior segment. We can measure different parameters. You can do lots of calculations in the angle as well. So what is the role of all these angle calculations? To provide reproducible criteria, and when you want to document change either over time, longitudinally, or with your treatment. In primary angle closure glaucoma, the iris would be thicker, the trabecular ciliary process distance would be shorter, and overall the angles would be narrow. And acute angle closure glaucoma having the narrowest recess of all of them. We also know there are a lot of risk factors which predispose a patient to primary angle closure or angle closure glaucoma. So all these anatomical risk factors which are there, we can measure through a UBM. Iris thickness, if you see, we know in angle closure glaucoma you have a thicker iris, so you can measure the iris thickness at different points, that is peripheral, mid-peripheral, and near the pupillary border. And you can see here, in the periphery towards the insertion, this is a thin iris, but the same iris pattern towards the insertion, it is still a thick iris. So this is more likely to get closed down. A shorter trabecular ciliary process distance, it is more susceptible to occlusions, the distance from trabecular meshwork to the ciliary process, and it plays a very important role in subsequent development of peripheral anterior synechia. All the guidelines, the American, the Indian, and the Asia Pacific, all of them, the European, they say that UBM is one tool which has the greatest range of anatomical information. But you have to keep in mind that this is a contact procedure. All the quantification that we do with UBM, it requires a subjective input about the location of the scleral spur. So if your scleral spur marking is inaccurate, all your calculations and measurements are going to be inaccurate. The longitudinal assessment that we do over time or after treatment, again we are unsure whether the same region is being scanned each time. So that again you need to have certain landmarks in mind, and that might give you a certain amount of measurement variability also. Again, to reiterate and emphasize on the same point, all these imaging technologies cannot detect subtle pathologies like goniosynechia and pigmentation, which are so very important for the diagnosis and management for primary angle closure disease. So all this cannot be picked up on UBM and can only be seen in a gonioscopy. So it is definitely a very useful tool, but only as an adjunct and definitely not a substitute for your clinical assessment. Thank you.
Thank you, Purvi. Now we have Dr. Mehta here. Believe me, for the beginner to identify the landmark is so difficult. First, you have to identify the scleral spur, and it is more difficult with the UBM compared to the anterior segment imaging. So, Dr. Mehta is going to teach us how to identify various landmarks using the imaging. Mehta, please.
Yeah, it's loading. Thank you, Dr. Mayuri and AIOC Organizing Committee for giving me this opportunity. So I'll be talking on identification of the anterior chamber angle landmarks and quantification on ASOCT. So we know that angle can be assessed by gonioscopy, which is a direct visualization, but it needs diagnostic contact lenses. The limitation is it is objective and qualitative assessment. Imaging can overcome these limitations and it is useful in clinical practice as well as for research. OCT is a new tool which has given us this possibility, and we can see all the structures which are involved in the pathogenesis of glaucoma with the help of ASOCT. Obviously, we cannot see anything which is beyond the iris because it is an optical tool. It provides a definition of ocular tissues which is comparable to histology and comparable to those obtained with UBM. It is more useful than UBM for serial monitoring of the angle because we can align the same ocular landmarks and we can have a capturing of video images also during scan acquisition. Great potential for identifying patients at risk for angle closure. It is non-contact, can be done with any lighting conditions and can be performed by a technician. Ophthalmologist is not required. Angle assessment with physiologic light conditions also can be done like photopic or scotopic in the same setting. So evaluation of patients for static and dynamic biometric risk factors is possible with this, and even secondary glaucoma can be assessed. Assessing the efficacy of glaucoma interventions also can be done with the when we do laser PI or if we do glaucoma surgery. So, but the ASOCT from different devices is not interchangeable. Qualitatively it may be, but quantitatively definitely not, because the OCT technologies differ, the parameters are different, there are algorithms are different, so it cannot be interchanged. So it is also helpful in patient's understanding. If you show this diagram to the patient and show his diagram that your angles are occluded, he immediately understands what is going on and what needs to be done. So let's find out these structures. So this is a gonioscopy diagrammatic which we all know. We all know the structures, where is the Schwalbe's line, where is the Scleral Spur. So let's see them now one by one. So here is the Schwalbe's line where the wedge of the cornea is there. So, and the next is the Scleral Spur. So Scleral Spur is defined as the inward protrusion of the sclera, where a change in curvature of the corneoscleral junction is observed, and this is at the junction of the trabecular meshwork and the ciliary body, that is here. So Schwalbe's line, we know that it is a wedge shape, and here you can exactly find out where the descemetes end. So that is the area where the Schwalbe's line is. So, and this is a between the length of the trabecular meshwork, that is between the Schwalbe's line and the Scleral Spur. Schlem's canal also can be identified behind the trabecular meshwork. It extends from the SS to the anterior tip of the trabecular meshwork at the end of the descemetes membrane. So this is another one more thing which we were seeing on histology, but we can identify on ASOCT, that is band of extracanalicular limbal lamina. This is defined as a hyporeflective band wrapping around the trabecular meshwork and the Schlem's canal, and it was previously identified as TM shadow. The importance of this is that in open angles it has a better visibility of the these landmarks, including Bell and the Schlem's canal, compared with the closed angle. So this is the hyporeflective area which we are seeing behind the trabecular meshwork. So here we can see the structures. This is the trabecular where the descemetes membrane ends. So this is the Schwalbe's line, this is the corneal wedge, and this is the Scleral Spur. So these structures can be identified very well with the ASOCT. Now here again Schwalbe's line, the corneal wedge, and the Scleral Spur. So this is trabecular meshwork. So other biometrics which can be identified on ASOCT, which are predictors of VACD, and they are classified as static risk factors, and these are the anatomical risk factors for VACD, and which can be measured in a single ASOCT image. There are also dynamic risk factors which can be evoked by structural changes associated with pupillary dilatation or constriction. So lens vault, as we had discussed earlier, is a major risk factor. This is a perpendicular distance between the two scleral spurs, line joining the scleral spur and the anterior vault. So this is a novel parameter, and the higher values are associated with crowding of the anterior chamber by a thick lens, and it has a 48 times higher risk for angle closure. Anterior chamber depth, we all know. Anterior chamber width is the distance between the two scleral spurs. So this is again a parameter which is a very recent parameter, and this is an indicator for angle closure. So this is still under research. So another is anterior vault, which is a addition of anterior chamber depth and lens vault. So relative LV is calculated, which is lens vault upon the anterior vault, and this is again a good tool for prediction of and patient's risk of primary angle closure, and used as a screening tool. So as the ACD decreases, the lens vault increases, and patients with larger RLVs have PACD is common in these patients as compared to the normalized, and it is a better indicator of PACG than lens vault. So static risk factors include iris thickness, iris area, and iris curvature, that is the line joining the distance between the line joining the two ends of the iris and the posterior iris curvature. So next is angle opening distance, which can be 500 and to 750 from the scleral spur. The next is angle recess area, that is the area between the ARA 500 and 750 and the anterior iris surface and the inner corneoscleral wall. And next is TISA, that is a trabecular space area. This is a perpendicular distance between the scleral spur and the opposing iris and AOD 500 or 750. So static risk factors, if we see these, there are multiple studies. So in hypermetropia, all these risk these parameters are less as compared to other refractive errors, that is myopia, astigmatism, or very high myopia. So these can be predictors of angle closure and crowded anterior chamber. But still there are some researches and studies which show that they are not so important, and this is because of the anatomical variations along the 360-degree span of the angle. So angles are more narrow superiorly and inferiorly, and open temporally and nasally. So this anatomic variation is there. So we need a multi-image approach to scan the angle, and not just 2 or 3 straight line scans. So iridotrabecular contact, that is ITC, is coming as a major predictor for a angle closure, and this is a presence and detection of ITC is a hallmark in eyes with angle closure glaucoma. It is vital in deciding about laser iridotomy and also effect of laser iridotomy. Indentation and darkroom gonioscopy is a gold standard, but still now this is coming, and this has been getting compared with the routine gonioscopy that we do. So Itc Index gives an extent of angle closure in 360-degree circumference. So the red circle is the scleral spur here, and the green line is the end point of ITC. So we can exactly measure the index. So you can see the blue area is the contact of the trabecular meshwork to the iris. So this is a area of ITC, and here we can see that there is a change in ITC index, that is 67% contact was there, which has reduced to 35% in PSAG after a laser PI. So this is an important finding, and maybe it can be considered in future studies. So coming to dynamic risk factors, so these are the structural changes of the iris with dilatation. Iris behavior in the dark versus in the light differs significantly between PSAD and normalized, and this is a risk factor for occludable angle, is the post dilatation less reduction in the iris area and iris volume as compared to the normal patients. So dynamic risk factors, this is one study which shows that peripherally distributed iris is a risk factor, and less loss of iris area per millimeter of pupillary diameter also is a risk factor, and in logistic regression analysis this has been proved as a risk factor for occludable angles. So these are some slides. Now here you can see that this is a photopic pupil in a routine sitting position we are taken, and a scotopic. So the iris definitely contracts and the angle gets occluded even in a normal patient, as you can see here. So here also photopic pupil and angle and scotopic pupil and angle. So you can see the reduction in the angle qualitatively also. Classification based on ASOCT can be, we can have this. This is one is the pupillary block, Plateau Iris mechanism, thick peripheral iris, the C is, and the D is the exaggerated lens vault mechanism, and this also we can see in our real life patients. So this is a pupillary block with oppositional angle closure. The next is a Plateau Iris. You can see the iris very narrow recess and a table-like structure over here. So that is a Plateau Iris. Here you can see the thick peripheral iris which is blocking the angle totally. So this you can identify, and again the exaggerated lens vault mechanism like in UBM also. So this is qualitatively also you can say that the angle is 0 without measuring it, and there is a oppositional angle closure, and post PI the angle is opened in both the eyes. Again this is a peripheral angle which is a narrow oppositional angle, and this is pre-dilatation. We know that the angle is opened and the recess is opened up, and even on post-dilatation you can see that there is less opposition, and you can dilate the patient very whenever you want. So this is oppositional angle closure pre-iridoplasty, and this is post-iridoplasty. So immediately you can make out the difference in this. And this is a convex iris in pigmentary glaucoma, which we see very often, but we don't know how it looks like on ASOCT. Chronic angle closure, as you see here, you can see the peripheral anterior synechiae which is pulling up the iris, and the angle closure in this both the eyes here. Again, PS following a shallow AC, probably post cataract surgery there was a shallowing of AC, and you can see the angle which is totally occluded. So this is also a patient of peripheral anterior synechiae. Patient of inflammation post phaco plus IOL, you can see how much inflammation is there, and the occlusio pupillae along with iris bombae. A patient of say uveitic glaucoma, and here you can see the obviously we did a PI here, but we cannot do a far peripheral PI because hardly there is a space, but so we did a mid peripheral EPI here, and immediately after PI the angle opened up and the pressure came down. 1 minute, it's okay. Yeah. So this is a patient of angle dysgenesis. Post DALK, you can see the iris, the bubble must have gone behind iris, and there is a synechial angle closure. This is patient of NVG. You can see that the angle is closed over here. Even some vessels are seen here. Iridodialysis, ciliary body swelling is there along with hyphema, descemet folds, and cyclodialysis cleft over there. So ASOCT imaging is not to replace conventional gonioscopy, but it is to supplement and augment angle evaluation. Major advantages are it is a non-contact nature of the procedure. Repeatability and reproducibility is there. Quantitative and qualitative information we can get from this. May help in screening programs for PSEG. May improve our understanding of the surgery, and it is an invaluable tool for ophthalmic research. Thank you for your patient hearing.
Excellent talk, Medha. You made it so simple.
Thank you.
Now, Dr. Chandrima, she will be talking on the role of anterior segment imaging in the pseudophakic glaucoma. Till they are ready, I can ask one question to Medha. It is not always that simple on UBM to identify this scleral spur. Can you guide them how to do that?
On UBM or ASOCT?
UBM.
You can answer it.
Medha.
I'm more this thing with ASOCT. So ASOCT I can.
Yeah, so for the UBM actually there are 3-4 indicators by which you can identify the scleral spur. One is the change in the reflectivity which you see, because as the transparency and reflectivity of the tissue of the cornea changes to the sclera, so there will be a change in that reflectivity. Second is that small notch or projectile spur kind of an appearance that you see, because again, as there is a transition from the cornea to the sclera, that small spur kind of an elevation which will be there. And third is what you can do is you can just trace the anterior border of the ciliary body and trace it anteriorly as it goes up till the cornea. So there again you can see the transition, and the transition will be the landmark for the scleral spur.
Very simple. AIOCT is because it is a high resolution image, and the simple technique is to start from posterior part and go anteriorly. That way you can identify scleral spur. Okay, Chandrima.
So good afternoon, everybody. And at the outset, I'd like to thank Dr. Mayuri Khamar for giving me this opportunity to be a part of her IC. And I'm going to take you through the role of anterior segment imaging in pseudophakic glaucoma. So pseudophakia does not cause ocular hypertension by itself, but Radius et al. Said that cataract extraction and IOL implantation do not cause a statistically significant increase in IOP. Secondary glaucoma in pseudophakia immediately after surgery or weeks to months later could be open angle, closed angle, or acute or chronic. So the early IOP rise can actually occur in all these conditions that you have here: malignant glaucoma, pupillary blocks, ACIOLs, iris-supported lenses, iridocapsular lenses, inflammatory reaction, loose cortical matter, obstruction of the outflow channels, loose cortical matter, the OVDs that we use, and of course post-operative steroids. And the late intraocular rise of pressure can occur in the uveitis glaucoma hyphema syndrome, prolonged outflow obstruction, traumatic scarring, inflammatory reactions, iris vitreous incarceration, synechia formation following that, presence of vitreous in the anterior chamber, secondary glaucoma, pigment dispersion, or host cell glaucoma. So the anterior segment OCT, it's a non-contact rapid imaging device. My speaker's predecessors have actually done my work for all this, so I wouldn't go into the basic principles and all that. I'll just tell you the advantages: semi-automated, not operator dependent, and has good reproducibility. Disadvantages, however, are lesser depth of penetration due to shorter wavelength of the light source. Ultrasound biomicroscopy, again, this has been spoken about by Dr. Megha very well. So I'll just again say the advantages: better to visualize posterior chamber structures like zonule ciliary body and anterior choroid, useful for evaluation under anesthesia, and disadvantages: poor intra-observer reproducibility. So again, the anterior segment OCT versus the ultrasound biomicroscopy. I don't think I'll go into this because you have heard all this from the previous speakers. I'll come straight to malignant glaucoma. Similar findings with ASOCT and the UBM: iridocorneal touch, anterior displacement of the iris root, appositional angle closure. OCT better resolution but limited visualization of the lens, ciliary body and anterior vitreous. Imaging of the anterior rotation of the ciliary body not possible, and UBM may not be convenient in the immediate post-operative period. So if you have a look at that there, the UBM, the anterior displacement of the iris root that you see out there, and the uniformly shallow anterior chamber, and after a pars plana vitrectomy, this is what you could see. And IOL-induced pupillary block, that's less frequent, but aqueous outflow through the pupil is blocked by various mechanisms. Could be anterior chamber IOL, where pupil occlusion is by lens optic, peripheral iridectomy in all cases works well. Then posterior chamber IOL, post-operative inflammation, aqueous accumulation between posterior capsule and anterior vitreous phase, IOL in the sulcus, which actually alters the anatomy there, and incorrect inversed IOL implantation. That is, of course, a wrong opposition and less common with modern phakic IOLs. So may occur in the immediate post-operative period or even years later. The risk is higher in diabetic patients and in glaucoma patients who have already angle closure. So if you look at the UBM there, the PCIL apposition that you see with the iris out there, easily visible. And again, the UBM or ASOCT would show you the high vault in a phakic IOL. Uveitis glaucoma hyphema syndrome, or the Ellingson syndrome, that's intraocular caffing due to IOL. So UBM is used to visualize the malposition of the IOL haptics and contact with the uveal tissue, as you see out here, and you can see it here also clearly. So post-operative inflammation, obstruction of trabecular meshwork by inflammatory cells, fibrinoid erythrocytes, the risk factors, excess manipulation, retained lens matter, preoperative or uveitis, and may lead to peripheral anterior synechia and pupillary block. OVDs in the anterior chamber, we do use a lot of high molecular weight OVDs nowadays. So reduction in aqueous outflow due to the trabecular meshwork blockage, and transient peaks are generally there between 4 to 7 hours post-operatively, which again returns to baseline within several days. And sodium hyaluronate definitely has a higher risk than your HPMC. So peripheral anterior synechia, chronic angle closure, risk factors are flat anterior chamber, wound leg, or inflammation, as you would see that in the ASOCT that you see out here. So vitreous in the anterior chamber, which can cause pupillary block, blocking of the angle and preventing drainage. So that could be very clearly seen in the UBM, pupillary block caused by vitreous in the anterior chamber. Pigment dispersion, transient rise in IOP, open angles, risk factors are IOL in the sulcus or an AC IOL. So gonioscopy would show you heavy pigmentation of the trabecular meshwork. The UVM would actually show you a concavity in the iris and increased iridozenular contact. So in summary, surgical intervention may lead to glaucoma. Careful instrumentation during surgery is very important. Care for pre-existing glaucoma, intra and post-operatively is mandatory. Adequate post-operative steroids, keeping in mind steroid-induced intraocular pressure rise, and judicious use of anterior segment imaging in the diagnosis and monitoring of response to treatment in these eyes. Thank you very much for your attention.
A line I would like to add here is we have done an extensive study using the UBM in pediatric age group, and we found that the abnormal position of the haptic of the lens, or one haptic is in the bag, other one has come out, and it is irritating the ciliary sulcus and ciliary body. Those could be also one of the very important cause which cannot be identified using gonioscopy or simply on the slit lamp. So UBM plays a very, very important role in the pseudophakic glaucoma where the mechanism is not clear.
So thank you, Dr. Chandrima. And in these sessions, talks, we have understood how anterior segment imaging actually helps you to diagnose the pathology, and also it helps you in the decision making for management. But anterior segment imaging also helps you to understand your post-surgical status and the effect of your intervention. So that is what Dr. Mayuri will be talking about, the chief instructor, and the role of anterior segment imaging post-glaucoma surgery.
Thank you, Purvi. So trabeculectomy still is the most effective filtering surgery, even though more and more surgical options now are available to us. Long-term success rate is very good. At the end of 15-year study, the 67% of the eyes were under control. This is the study which was done by Chen et al. And this graph is showing you that in the early phase, there is a steep fall in the success rate. And then there is a moderate cases which are showing the failure. And at the end of 20 months, there is hardly any failure. So if we can see, if we can do so in the early phase, then we can manipulate and we can prevent the failure of that trabeculectomy. Now we know that the bleb morphology is known to be an important indicator of the bleb function. Moorfield classification everyone is using. It gives us area of the bleb, maximum elevation, height, and the vascularity. While the Indiana bag morphology classification also includes the leakage of the Seidels positive in that bleb area and how much is the leak, one or multiple point leak or the sweating bleb. This all decides the success. And the latest one is the mains bleb appearance grading system, which also includes the vascularity of the bleb area and the transparency of the and the mobility of the bleb conjunctiva. These are also important factors for the success. So microcyst appearance, bleb transparency, and the conjunctival mobility is included only in the last one that I said. Now we know that the anterior segment OCT is a promising tool to image the trabeculectomy blebs. And it can demonstrate the features of bleb morphology which are not visible with this simple slit lamp. So these features of bleb morphology, which is not visible on the slit lamp and visible with the OCT, can help us in evaluating the functionality of the bleb in very, very early post-op period. This is a cross-sectional image of the bleb showing you a subconjunctival fluid space, bleb wall, then small cystic areas, anoic areas. Then this is the suprascleral fluid space, root beneath, and the sclerostomy opening, how big or how small it is, and the iridectomy. There are other features also that I will describe later on. The ideal bleb should have a vascularity of the bleb similar to the surrounding conjunctiva, numerous microcysts, diffuse bleb, and moderate elevation. So the anterior segment imaging can show us all three features which are important for the functioning, good functioning of the bleb, except vascularity. Now the same elevation, good looking bleb can have a different features as shown in these three slides. One has a large cystic space, the other has a spongy look, and this has a various separated layers of the subconjunctival area. It could be a dyspeptic look on the slit lamp, avascular bleb, diffuse bleb with a large area, may not be always good functioning bleb. As shown in this, there is a hyperdense echoes in this area which is suggestive of fibroblastic activity. Eventually this bleb may fail. So cause of failure, we know that it could be a subconjunctival or suprascleral fibrotic area or the occlusion of the inner ostium that we have to look for doing the gonioscopy. So coming back to the first slide that I have shown, can we predict the early failure? Can we recognize early so that we can prevent the failure, and we can by managing it better by giving injections, or we can do the needling also at that time, or release the releasable suture. So the most important step in the management of failing bleb is to recognize its presence. And that is why we undertook this study to correlate the morphological feature of bleb on the anterior segment OCT at 1 month with the bleb function surgical success at the 6 months. The cross-sectional images were taken from the radial part as well as the tangential area of the bleb. So bleb wall reflectivity could be uniform reflectivity, or it could be multiform reflectivity. Uniform reflectivity usually is a sign of the failure, and the multiform reflectivity with the tiny cavities of the aqueous drainage is a sign of the success. Now multiform bleb wall reflectivity again is divided into multiple internal layers as shown here, or it could be subconjunctival separation like this, or it could be multiple microcysts like this. So the last one, microcyst, is an ideal bleb and is always a 100% successful bleb. The root beneath can easily be identified using this technology. So you are sure that nothing is occluding the outflow facility. And this is the conclusion we had with our patient study, that if patient has a microcyst with the subconjunctival separation, it is showing 100% success at the end of 6 months. The OCT was performed at the end of 1 month of the surgery. So bleb wall with the multiform reflectivity shows increased chance of success of functionality of filtering bleb at 6 months. And the pattern should be multiple internal layers as well as microcyst. Now this is a Japanese study which was published, and in addition to what we have said, they also calculated the opening, filtering opening, which is seen from inside. And larger the opening, more is the success. That is what also they concluded. Now 2 eyes can behave differently. These are the 2 eyes of one same patient. One has a large anoic area with a sponge here, and this is a huge bleb with just a spongy look. Now early post, let me share this case. After 10 days you can see the flap bleb. Few vessels are also coming up, tortuous vessels, and the pressure has started showing rise. So what to do? So should we remove the releasable suture? And this was the pre-release. You can see the uniform reflectivity of the bleb, almost flat bleb. Immediately after the releasing of the bleb, you can see the multiple layered subconjunctival separation and the anoic area on the suprascleral space. Now, the dreaded complication of use of mitomycin bleb is the leak or the hypotony and thin avascular area and likely to be blebitis. So the new technology modality is there. Ologen blebs are used to have a thick wall blebs. And what happens with these blebs? The natural history. The ologen implant is a biodegradable. By 3 to 6 months it dissolves, leaving behind its space a fibrous sponge, a negative copy of the original one. I will share few cases of mine. First, if you see, this is immediately after the surgery. There is a ologen which is sitting here and this is the later phase. There is a shrinkage of the ologen later on, and the anoic area is coming up exactly on the top of the sclera. And these are few microcystic areas. This is after 6 months of the surgery. Now this is day 1, clear zone on the side of the ologen and homogeneous appearance here. This is after 3 months. Something is coming up. There is a shrinkage, height has decreased, and the clear area is coming up here. And at the end of 6 months, good anoic areas, aqueous pockets are coming up, lamellar separation is coming up, but uniform reflectivity is on the top. So shrinkage will leave behind the aqueous pockets underneath the bleb wall. So it is not a thin bleb like mitomycin, but good healthy bleb with a good filtering areas. And expression, you can see where is the position of the tube, a stent, and how good is the bleb. And the tenon cyst, you can identify whether it is successful after the needling procedure. So for me, implication of AIOCT is to identify the internal structure of the bleb, thereby providing better understanding of bleb morphology. It can predict its success or failure at early postoperative period. So we have a scope of early intervention in the bleb with a poor functional outcome. So the limitation, as I said in the beginning, vascularity of bleb cannot be seen. Leaking, sometimes if you can correctly place it in that particular area, you can see the break. And the longer duration follow-ups are required. That is the limitation. Thank you very much for your patience here. If you have any questions, we can take up now. Speaker is now unbiased view, whether what is the present day status of this imaging, that Dr. Paul is going to.
How do you take these images? How do you take these images?
I've shown you in one of my chart. Wherever is the highest.
He's asking whether you have a video, like somebody is taking a video, how you are taking the picture of the patients. Like someone else is taking a video.
When you exactly do the
Imaging, there are options available in the Visante. You can take correct section from the maximum elevation in the center of the bleb. One is vertical and the second is radial, perpendicular to the limbal, away from the limbus, but where is the highest elevation. 2 sections you have to take, cross. So now Dipanjal will give us the unbiased view. What is the present day status? Where should we use this technology? And nothing. What happened? It is available with the other PSOCT as it comes as a duo. Yes, they do have. I am using Zeiss. She has used Topcon.
You get a corneal view also. Exactly you can't get. Color picture you can get it exactly.
In all the technology, there are options to, you can go with the grayscale or you can go with the hot colors. That options are there in the software.
Good afternoon, all. At the outset, I would like to thank Dr. Mayuri to give me this opportunity. So I will basically summarize the whole whatever we had seen in the last 5 speakers. What is the current day status? So the major beneficiary is definitely angle closure disease, which has high visual morbidity. And we all know that the early detection of anatomically narrow angles is important because a combination of various anter-segment techniques gives us a clear picture of the anatomy that helps to make an appropriate treatment decisions. So we know that indentation gonioscopy is definitely the gold standard for assessment of angle, but it has got drawbacks, like it has got subjective variation, and that there are various types of lenses used, and there is usually a steep learning curve, and there is variation of the assessment in different ambient illumination. Placement of the lenses, sometimes mechanical pressure is there, so it has to be avoided in damaged epithelium or opaque corneas. So the objective assessment of antechamber angle can actually be done either by a photographic method or by an optical method. For photographic method, it is usually, we have ICAM, which is a portable handheld device used in dark illumination with supine, usually very good for children. And it gives us a direct imaging of antechamber angle through almost 130-degree wide field lenses, and the data captured, they goes through a computer assembly and we get the picture. So it is actually a good objective method of visualization of antechamber angle. There is moderate to excellent intra and inter-observer reliability, and good agreement with gonioscopy shown in several studies. But the drawbacks are there is poor depth assessment in narrow angle research when compared to antechamber OCT, anter-segment OCT, and is influenced by position-related changes. Pentacam images the anterior segment from cornea to posterior surface of the lens in 3 dimensions, but the major drawback is there is direct visualization of the angle recess is not possible. Anterior segment OCT and UBM are 2 most commonly used devices and discussed extensively in our with our predecessor speakers. And this anterior segment OCT is a non-contact rapid imaging device that uses low coherence interferometry to obtain cross-sectional images. It has got good reproducibility, and it is non-operator dependent, and patients are on sitting position, that is the best, and is known to have higher sensitivity when detecting angle closure compared to gonioscopy, but it is actually less specific. And there are various types. The bottom line is, if we increase the wavelength, like from 800 nanometer to 1310 nanometer, we are going to have better axial resolution and better depth range. And the moment we are using the swept source ones, the line scan rate is increasing by almost 10 to 100 times. So it gives us a fantastic qualitative assessment, but it is very important to identify the scleral spur as already discussed, and it is visible as an inward projection of the sclera at the junction between the inner scleral and corneal curvatures, and the apposition between the iris and the inner corneoscleral wall, that is the ITC, which is very important, and we need to see that. Quantitative measurement of the antechamber angle is possible with a built-in software, and definitely it requires the identification of the scleral spur, and there are several parameters which have shown good reproducibility. These are already discussed. What is new is that there are several new AIOC parameters that has been associated with angle closure, which includes smaller AC weight, smaller AC area, lower antechamber volume, larger lens vault, and greater iris curvature. And also, AIOC is invaluable for diagnosis of angle closure glaucoma, and it can detect clinically important changes in antechamber angle structure in patients with angle closure glaucoma under light versus dark conditions. And also, it can demonstrate widening of the angles after laser iridotomy. And not only that, it gives a clear indication when we follow up the patient following the laser iridotomy that certain amount of patients will have a non-pupillary block mechanism also, which may contribute to primary angle closure glaucoma in future. In this paper, Vascular et al. Looked at a cohort of almost 300 patients who had a gonioscopically open angle, but where they had detected iridotrabecular contact by Visante OCT, and they saw that the subjects with more quadrants of AIOC angle closure at a baseline had a greater chance of developing gonioscopic angle closure after 4 years, which was statistically significant. So thereby, AIOC can predict angle closure glaucoma, which is going to happen in future. The newer modality in this is a swept source OCT device. It is either from Tommy, which is called Cassia, or there is another called Anterior. It can rapidly obtain high resolution scans with 3D reconstruction. Why it is good? Because it is the probably it is it detects the spar far better than previous versions of OCT, and it is also excellent at calculating iris volume, which has been shown to be a very important determinant of future angle closure disease. This is another newer parameter called Itc Index. It gives us an assessment of circumferential 360-degree angle closure. A recent study by Bhaskaran et al. Demonstrated that this index is a good diagnostic performance compared to gonioscopy. ASOCT also has limitations. It cannot image beyond posterior pigment epithelium of iris. There is no use of opaque corneas or pediatric glaucomas. And quantitative assessment depends heavily upon accurate identification of scleral spur, which is important. And Madam has already shown there are new landmarks which are coming like Bell and SL. And there is, of course, no normative database in Asia. Coming to UBM, it has already been discussed well. And it is sound waves which are converted to high resolution B-scan images, but it has got lower axial resolution than anterior segment OCT. It has good agreement with gonioscopy. It is definitely invaluable for structures posterior to the iris pigment epithelium. Why? As because sound penetrates the pigment epithelium where light does not. It is particularly useful in opaque corneas and congenital glaucomas. Plateau Iris syndrome is definitely a situation where UBM is invaluable, and also it is invaluable to detect a ciliary body tumor and the area of iridojonular contact in PDS, and sometimes it can take out a GDD tube block. So the take-home message would be anterior segment OCT is a clear winner in ascistic anterior chamber angle when the cornea is clear and the patient can sit upright. UBM should be used when the cornea is cloudy and you suspect a pathology which resides behind the iris plane. And both these technologies allow the acquisition and comparison of objective data and the parameters, which is not possible either by slit lamp biomicroscopy or by gonioscopy. So the ASOCT and UBM prove to be useful adjuncts, but it can never replace the clinical examination by gonioscopy. At the end, let's look at what is deep learning is. The deep learning is an artificial intelligence function that imitates the working of a human brain in processing data and making decision algorithms. Application of deep learning is to assess the anterior chamber angle in ASOCT images has already been shown with encouraging results, and it is comparable with the diagnostic ability of a very well-trained ophthalmologist, and probably this is the future. Thank you for your kind attention.
Thank you, Deepanjal. Now we can take up any questions you guys have. Yes, please.
When we do gonioscopy, we can always do indentation and see there is oppositional closure or are the angles opening up. So is it something that if we use, for example, anterior segment OCT, we will be advising more of peripheral iridotomies and maybe, increasing the burden of laser rather than going on a little conservative approach if we do only gonioscopy?
There was a study done by Ramakrishnan et al. And they have shown that by using the imaging, you can identify a lot of angle closure, possible suspects. And that, you are right, absolutely. That may increase our burden to do laser PI. But we can use other parameters that they have discussed, both of them. Lens fault is also very important. Nowadays, the iris volume is also calculated. Look at the peripheral roll of the iris. If it is a thick roll, then the occlusion is likely to be happening. So, Medha, use micro.
Yeah. How do you measure the volume? Can you measure with the normal OCT?
Yes.
In fact, can I suggest, the counseling becomes so easy when you've done a gonioscopy. Is a subjective phenomena. Your eye say your angle is open, angle is closed. But here in anterior segment, when you see the angle is narrow, you can explain the patient. Even if the angle is narrow on a gonioscopy, you explain beautifully. But when you show it on the picture on the OCT machine, it becomes counseling easy. What I have done now, post YAG also, I do the OCT and show that this 100% perforation has happened. Sometimes it has happened, it's not very adequate opening. It's seen the anterior segment OCT. And I advise few more shots to be given. So it really works very wonderfully. And I take 4 directions, in the anterior segment OCT.
You can.
Yeah. So
It is so nicely seen with the cells in the extremes and the fluid coming from here, translucent area.
fact,
So immediately after PI, it
Dr.
is nice.
Mayuri, I say one paper I read about it, it says that do the screening of anterior segment OCT of the angle and then do the gonioscopy. You may find more.
Yeah,
narrow
actually
angles,
that
you
was
see.
what I was just about to say, that if you are using ASOCT as a screening tool, then you can pick up those suspicious
Yes.
cases
And
and
then-
then subject them to
Correct,
gonioscopy.
correct,
And
yeah.
in fact, gonioscopy may give you those small additional information like patchy pigmentation or fine goniosynecia, which you could not see perhaps in the ASOCT or anything. So then it's easier for you to decide whether to go for a PI or not.
In fact, yesterday only I had one case of a traumatic injury, and it looked like the stone at about 3 o'clock near the limbus. And whether it looks like a stone, but it may be a hemorrhagic phenomena. So I just did the anterior segment OCT and I found that there is no stone because the entry wound was there. So I was wondering whether I'm dealing with a intraocular stone. So anterior segment OCT works very well in majority of the cases,
Particularly when there is a trauma, penetrating trauma, or the hyphema is there and you would like to assess the angle. There also this non-contact anterior segment imaging will give you a lot of information. Yes, any more
And
questions?
one more question I mean, Plateau Iris syndrome, when we have a double hump pattern and we have done an iridotomy. For example, I mean, I am practicing glaucoma, but I do not have an UBM. So, I mean, what should be the general take-home message that if you have done a PI and if you see a double hump pattern and the pressures and the angles are not opening, do we label or should we always send the patient for a UBM to confirm for Plateau Iris before we do, or I mean just a gonioscopy and a PI and a double hump sign should be sufficient?
I don't think it is compulsory to do imaging. If you can identify on gonioscopy, it is a sign that there is an anterior rotation or some tumor is there. And Plateau Iris, the question is, should we do the PI or not? That is another question that I have put up here. It is to relieve the pupillary block element that patient has. So we have to do PI. It is not for the opening up of the angle. Okay.
For your question, sine wave sign on gonioscopy.
Yes.
You
That's
can
what I
look
was
for
saying.
that when you
Yes,
see
yes.
that in spite of a PI, the patient still has an angle closure. Look for the sine wave
And then
sign,
you do a
and then you send.
iridoplasty.
Then you send for a UBM if possible, because patients nowadays read up all the Google material. So if you don't get an UBM done, it's actually not a confirmatory thing for a Plateau Iris. So it's better to get a UBM done before you put the patient back on pilocarpine and say that you'd have to use pilocarpine for a long-term period, basically. Yeah.
Another option is actually, though it's not available right now, but you could even try pilocarpine. So if that changes the iris configuration and improves your IOP control, then that is another indirect evidence that probably it is Plateau Iris.
It's available now.
Dipanjal, you won't like to.
Yeah, yeah. Pilocarpine is available freely now for information. Yeah.
Yes.
Yes, the therapeutic diagnosis.
Drug of choice
exactly.
for Plateau Iris.
Yeah, yeah, yeah. And pilocarpine is freely available now.
Not available.
Really? It's
Not available to
in
our
Delhi
Not
NCR.
part
available,
of the
so we
country.
did speak to, from the GSI we spoke. No, no, we
No,
spoke
no,
from
no,
the
it's not.
GSI to
Delhi
about-
NCR
because
to
there was
Dr.
a raw
Chandrima, it's
material
not
crisis.
available.
Yeah. No, 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 it's available for last 1 month or so everywhere.
No, no, Chandrima.
Last,
In
no,
Gujarat
in
and Maharashtra, it is.
Yeah, Pilokite is available and
That
yeah.
is not available in Gujarat.
Not in Gujarat?
Actually, Dr. Chandrima,
But it's from Pune basically. It's from
But
Pune,
it is not
Pilokite.
available.
Yeah.
no, it's not available. I just wanted question not related to this because pilocarpine is not available. I mean, what do we do if you have to, can we make drops with using injection?
And that is too less in the concentration to affect the pupil and all.
It's not available. Delhi NCR, I'm pretty sure, we were struggling
It's
and
not available.
that is what I was asking.
It's not so effective. Not so effective.
Not so effective.
It is already diluted. No, so how do we, you simply put those drops, you don't dilute it, no? Diluted, no?
It's already diluted.
It's very diluted, that's what.
0.5.
Yes.
Carpinol that we
0.5%.
use intracameral.
I have used intracameral like pilocarpine for drops, and I have seen that in some people it actually works. Probably those people like they have either thinner iris or something, and in some people it doesn't work at all.
Yes, absolutely.
Maybe we can increase the dose and see. I don't know how that would work. Maybe instead of 4 hourly or 6 hourly, you give it 3 hourly and see. I don't know. That's a trial actually.
But
No,
no,
we
the
have- we
letter
have. We've
came
already
from
spoken.
FDC to one doctor saying that by the end of May they will start production. It
So I
is
think
the
you should try
government cap
online.
that is causing the issue because they cannot raise the price and the material is very expensive.
Raw material.
Raw material. They get it from Germany or somewhere.
The raw material was a problem,
Very,
but
very
that has been
problematic.
sorted out. So
But-
I don't know why you're not getting it because we are freely getting it. And I think that company, I can send you the, the details. It's in Pune.
We will,
so
we
you need
will
to
go
get
and
across to
talk to
yeah.
them,
Yeah.
definitely. Any more questions in relation to the imaging? Back to the originality. Any concluding?
I can just ask one question.
Yes.
As if we practice anterior segment this OCT frequently always in our OPDs, then we are actually going to detect more PACS cases because it is definitely more sensitive. It is definitely more sensitive and less specific. So based on this AIOCT Itc Index or whatever the amount of iridotrabecular contact that is happening, are we going to actually advocate laser peripheral iridotomy for all these patients or not?
She just answered.
Yeah.
Actually, this is used as a screening tool, so you can always do gonioscopy and confirm. You do photopic and scotopic, how the iris is behaving, and after that you can just give knowledge to the patient. So patient understands what is his anatomical position of the eye, and whenever there are symptoms, you make them aware of the symptoms. So whenever the symptoms are there, yeah.
Good enough thing, like we are basically making the patient more aware.
Aware.
You were come to this community of angle closure sasa.
Yes. And there is a very simple solution if you develop symptoms. So whenever you have symptoms, please come. We can do whatever is needed. So that in that message should be given to the patient.
Yes, it's a good tool as a screening and as well as counseling to the patient. Once you show them anatomy and dynamic changes because of the light, they do understand and they yes.
No, I use in every patient. May not charge them. There's a different issue.
Sir,
But there's no
charging,
harm.
in private we do charge them.
Few of the-
We
It's a
can't
very
do it
beautiful
free.
tool to see the angle.
It's expensive but very useful at times.
As a retina surgeon, I want to ask, if you're not dilating the pupil, then how are you going to see the retinas? Because the corollary is then you'll have to buy Optos.
You have that small pupil camera, sir. Fundus camera, you have it. Full fundus view is
Very expensive.
yes. So
But if that's what, no, the answer to this is, if the patient needs repeated retinal examination, you better do PI.
better do PI.
Yeah, that is
That
one
are
thing. And
relative indications of PI.
yesterday, actually, I was in a session which was very interesting under the Apple Tree Innovations. So there, we have people who are actually coming up with really inexpensive tools where you can actually see the fundus and the disc without dilatation of the pupil. I think once they're available commercially, we will be a long way ahead. Yeah.
So we conclude the session here, but I would like to give you a message from GSI that we have a physical meeting in New Delhi this time in the month of November, middle of the November. You will be sent the circular shortly. So please do come. We are going to make it very interactive and interesting program.
And probably for next year onwards, we will not have to tell that it is going to be a physical meeting.
Yes, hopefully. Thank you.